Good afternoon and good evening, folks. Thank you so much for inviting me to share and exchange ideology on this very reputed platform called AIM Academy. And I wish the world a speedy recovery from the disasters caused by COVID-19 these times. Yes, we will, and the earth will heal soon. Thank you, organizers, for introducing me to my new friends and colleagues who have spared their time, who have joined us for learning the new concepts and techniques in Zygoma and Pterygoid implantology, especially surgical and prosthetic. So I would say the common surgical and prosthetic sense prevails and drives us ahead in bringing long-term predictability to our calculated tilts to these implants, which works in a synchronized manner after cross-arch splinting. I would be strictly recommending 2 points before I start with the presentation. First one is the learning capability, and second one is your practice. What you have learned, what you practice afterwards. So you have wonderful repeated online presentations to learn, to practice, and especially during these COVID times. So we can utilize them in a very good manner. So as the first slide says, we are just instruments in the hands of God. We always pray to Almighty, to nature in different forms, that He should always be besides us, because we do what He signals, what He or she signals for the betterment of the humanity. As I said, learn and practice and execute. Execution is must. So what do you need? In Stay happy in whatever little things you get in life, whatever time you get to spend with your family, your near and dear ones, because that is what we are living for. And yes, satisfaction is much required, because this is what we want as a clinician, and this is what our patient wants from us, because they want that it's their hard-earned money, so they want that it should be spent well, and accordingly they choose the clinicians. So the fear exists only in the mind, isn't it? Once you overcome that, you will do wonders. And who else will do? Because you are the instrument in the hands of the God. So carry that confidence that I have done good and good for others in my life, and I will be doing good. So whatever you learn, you practice. And I would say that 9 years ago, for what we have gathered here to learn Zygoma and Pterygoid implantology. And what we used to do, 9 years ago, the technology was not so advanced, society was less active on social platforms, difficult to approach your masters to learn. And now all things have turned the other way. Everything is so easy. It's only your will to learn, your gist to learn, to go further, to satisfy yourself. So 9 years ago, what I used to do a lot of grafting, sinus lift procedures, and this is the way, like, the world is advancing. Whatever you feel is good for your patient, the treatment modality, you change accordingly. So keep learning. So we used to say that no one should die without teeth, just because with their teeth in a glass of water. So I've just modified it to another statement called no one should die without teeth just because they do not have enough bone to hold on. Because your eyes cannot see what the brain doesn't know. So now our brain knows that we have zygoma. So when you see an OPG or a scan, you look for the bone in the zygoma, and then you say that yes, you will get fixed teeth. The patient will not die without teeth just because they do not have enough bone to hold. Because in sinus lifts, we augment a lot of bone, but we are not sure that we will be able to turn that graft into bone in all the cases. So this is how it goes, and it takes a lot of time, patience. So the Zygoma implants have changed that protocol, and Zygoma implants are an evidence-based surgical and prosthetic solutions for both two-stage and immediate loading protocols. And today we use them especially for immediate loaded cases. Just have an overview what we are going to learn today, what we are going to see, and how we plan the case. We choose implant Swiss from the library, and we introduce the scan, and then we play with it. We choose the positions where we get 360-degree rotation, and we see that we get bone all around the apex of the implant, because we need to engage our apex in the zygoma. So when we rotate the scan to all its axes, we find bone all around. So prosthetically, we set the position, and this is how all the four implants are positioned, and we fabricate the guide, or we plan the freehand surgery. So for beginners, I would be recommending that we fabricate guide with one of my friend, Dr. Anshul Mail from India. We are partners in for the wonderful patent we have called Dr. Zygo. These guides are patented under the name Dr. Zygo, where we get straight line access and we safeguard important structures as a beginner. So the guides are placed and screwed, and then the orientation, you drill and prepare the seat, prepare the osteotomy, and introduce your implant. We will see. This is just a beginning. We will see everything in detail. But this is just to show you what we are going to discuss here. We are going to discuss the freehand zygoma surgeries, pterygoid surgeries, and this lecture will emphasis on the surgical, how to place zygoma and pterygoid implant. We will see the documentation, but there are a lot of documentations available on the web and publications which you can explore. But for what you have gathered here today is to learn its practicality, how to prepare the seat, how to introduce the implant, and why we choose our different systems according to their design. We are thankful to Professor Branemark and Weischer, who cited the use of zygoma implant long ago in 1998, and they have said that, published that they have got more than 95% of the success in their placements, and which all cases they have met with the failure were because of sinus infections. So there are different authors who in different years published their different studies, and all of them have got more than 95% as the success rate. And one of the publication said that survival analysis of endosseous implant in grafted and non-grafted edentulous maxillae. They said that the implants which are placed in grafted are slightly lesser in the success rate than in the non-grafted edentulous maxillae. And yes, there are different publications who again said that we have done so and so number of cases, and most of them they have got more than 95% of the success in their thing, in their study. So, what are the indications for zygoma implant? Atrophic maxilla, of course, you know that the patient who comes to you with the atrophied jaw, we used to fabricate complete denture initially, but now we have the option, and very confidently I can say that we will be able to, as a beginner, we will be able to achieve the success. And if I have done that 6 to 7 years ago in my clinic under local anesthesia, yes, now everyone can do. So because that fear was there in my mind when I started, but it took me long. It took me 1 year to decide to jump into zygoma implant, and that was, I thought, like no, I shouldn't have done. So when you know, when you buy a new house or a new car, you get used to the things, you get used to the technology, but sooner is the better. And another indication is challenge for regeneration in such cases where, like vertical bone augmentation, we cannot anticipate bone formation all the time. And in cases where a demand for immediate prosthesis, where your patient cannot wait for longer time for sinus lift procedures, for augmentation, and we don't know whether he's going to get infection during the process, leading to failure of the whole thing. So then he loses his interest to move forward. So those cases now we do with the zygoma implants. Very familiar picture where we say that when you don't have bone in zone 1, zone 2 and zone 3, what do you do? Most of the cases we get bone in zone 1, but we don't have a bone in zone 2 and 3 in atrophied classification. So what we do, we place 2 implants in zone 1 and zone yes, bilaterally in zone 1, and then you can see the zygoma here. So one implant here, another one here. Then you choose in the canine region to go in the tilted direction to place zygoma bilaterally. And if pterygoids are able, are available, then yes, you can place implants in the pterygoid too. So this is the picture which shows you what all kind of cases we can get. So quad zygoma, where we place 4 implants, and unilateral. Here you see on the left side you place 2 zygoma, where this is a case of hemimaxillectomy, and where you see 3 implants, regular implants in combination. And similarly, there can be many combinations, mix and match combinations with the zygoma and the pterygoid and the regular implant. And yes, the common sense again prevails that you have to splint the whole arch to get those prosthetic forces in synchronization. Initially, what we used to do, we used to create a window and go palatally. But as the time moved forward, we changed the concept and we made it easier. Our colleagues, our senior colleagues, and many eminent clinicians, they made it easier to bring it into our practice. I'm signaling this to when we perform the procedure under local anesthesia. It becomes very easy for the patient to accept the protocol. So this is how we used to do initially. The whole implant is threaded, The whole implant is threaded, and the approach was palatal through the sinus. And where is the anchorage? Superior inferior border of the zygoma, then lateral wall of maxillary sinus if it gets engaged, and in the palatal. So 4-point cortices, cortical anchorage, and the prosthetic screw is palatal. So here patient used to get the alteration in speech, difficult in maneuvering the phonetics, and then it changed to extra maxillary. The blue line which you see, the direction is being shifted from intramaxillary to extramaxillary, where the crest of the implant lies on the alveolus, and the middle portion of the implant is along the lateral wall of the maxillary sinus. And threads are only at the apex. The portion which is going to get engaged in the zygoma, remaining body of the implant is smooth. Why? Because we don't need threads throughout. Now we are extramaxillary, and these threads, they used to create a lot of infections, bacterial load. They used to attract bacterial load along with the threads, and in turn causing chronic sinusitis or prolonging the sinus infection. So the designers, the innovators, they changed it to smooth surface implants. Thanks to Aprecio, who brought this classification, and I'm really thankful to him that he has given this idea where he has contributed a lot to the evolution of this technique, and this is called Zygoma anatomy guided approach, Zaga. Zaga 0 is when you see the maxillary wall, it is flat, and when you introduce the implant, the body of the implant is intrasinus, and anchorage is in the zygoma bone, and the crest of the implant lies on the alveolus. So as the concavity of the wall, it uh, goes, it becomes shallow or more deep. You call it Zaga 1, Zaga 2, Zaga 3, and Zaga 4. The more concavity it shows, the more your body of the implant is outward, not in the sinus. So Zaga 0 is when your body of the implant is in the sinus, when only 50 or 40% of the implant body in the sinus. And here you see in this picture, almost the body of the implant, the complete body of the implant is extra sinus. It's not intrasinus. So this lies in Zaga 4, and likewise, Zaga 0 is flat and 4 is towards completely extramaxillary. So this is an example of Zaga 2, where some portion of the middle part of the implant is in the sinus, and rest of the part is extramaxillary. Here it's more clear in this picture. Zaga 2, Zaga 3 almost extramaxillary, and Zaga 4 is complete extramaxillary in comparison to the body of the implant. So we see the contraindications. It's similar to the regular implantology, conventional implantology, where we see what are the patients which all patients we should not take in consideration for procedure. It's medically compromised patients, patients who have trismus, difficulty in mouth opening, because you need access to place the implant. When you're going to place implant in the left side, your approach is from the right side, and contralateral for the other side. So Even in cases where patient has normal mouth opening, but the patient lower arch is dentulous, teeth are present, still find difficulty in proceeding. So we plan it accordingly. And yes, where there are acute sinus infections, pre-existing pathosis, we don't choose those cases because we are bound to breach the epithelial Schneiderian's membrane. We don't know. Even if you scan, if you plan in the scans, you are not sure clinically where you will be able to conserve that membrane or not. So we should always see that there is no sinus infection, underlying infection, because you are going to tear the Schneiderian's membrane, which you are going to seal after you place the implant with the implant's body. So, but still, if there is a pathosis present, you should not choose those cases for zygoma implants. And yes, history of head and neck radiation. Of course, because bone turnover and bisphosphonates and everything, those are the contraindications which you already know when you are knowing this implantology. I assume that you already know how to place regular and conventional implants. So those are the contraindications which are applicable to zygoma implantology too. And what are the benefits of zygoma implants? Yes, it avoids the use of grafts in atrophied maxilla. No additional donor site surgery. We don't take bone from here and there. We place the zygoma implant in the patient's zygoma in real bone, not in the grafted site. And good anchorage from tough zygoma bone with excellent stability of the prosthesis, because most of the bone is the cortical, so it's a tough anchorage. And less number of patients visit, because in the same visit you can give the prosthesis. One day, 90% of your job is done, except the prosthetics. And if prosthetics are ready in hand, that also can be done. So this is the outcome of great clinicians, Bedrosian, Davo, Chow, Aprecio Molo, Professor Paulo Molo. Bedrosian also gave a classification on this. And they have said that they have done 5, 14, 18, 20, 42, different number of cases. But what they found here is the failure rate, like 0, 1, 2, 4. So these are the failures, and why they met with this failure, because of pre-existing pathology, sinusitis, and if not pre-existing, maybe recurrent sort of infections. So chief reason for the failure was sinusitis, and the survival rate which they have seen is 100, nearly 100 for almost all the clinicians. So now you can think that yes, I can do zygoma implants, because there are a lot of evidences available on the web which show you that yes, I can go with this. So let's learn how was Brainiac system looked like. It was the whole implant was threaded, and it we used to put it intramaxillary at the and the 40-degree angulation with the external hex was inbuilt. And these were the tools: driver and sleeves. These are the sleeves to guide the direction, and the depth probe and the yes, and the depth probe with the different markings which you can see on the handle. First marking shows you that you are 30, 32, 40 accordingly. First, second, third. We will discuss this in detail. And then evolution in design took place from Professor Brunomark to Professor Paulo Molo, who said that we don't require threads throughout the implant's body to to invite the infection. So it was changed to extra maxillary, where the threads of the implant are present only at the apex, and this region is considered to be as almost 18 mm. 18 to 20 mm, because most the studies have shown that the most of the bone volumes which are available throughout the world are in the range of 14 to 20 mm in case of zygoma. So the threads were kept at that length, and then the smooth body which is going to rest along the lateral wall of the maxillary sinus. And in some of the designs we have threads at the apex, at the crestal region too. Why? Because there were questions from different users that if in case of gingival recession, how to proceed with. So we need to have a good seal of attached gingiva, so that we don't meet that periimplantitis often in this case. But believe me that I have done many number of cases without the threads at the crest, and even if some sort of recession has happened, nothing happened afterwards, because I have 6 to 7 years follow up, and they all are doing nice. But now we have threads at this region for those kind of cases where we can anticipate the recession. So we will see that. This is another angle to show you that your threads are going to get engaged in the zygoma and rest of the body and the prosthetic connection. And if pterygoid, you are not going to place teeth, but you can get the connection from the pterygoid prosthetic connection like this. So implant threads at the apex, and this is the smooth surface. And we will see how to prepare the bed. This is how your implant looks like when it is completely seated in the site which you have prepared. And this is what I was talking about. The implant, which has been brought by Implant Swiss, that we can see, we can appreciate the threads at the crest. And another design where we don't have threads, it's simple with the smooth surface and the threads at the apex. So another advantage of this system is that we have inbuilt 45-degree angulation and the external hex connection. So if you want to convert this external hex connection to internal hex, you can to conventional prosthetic connections. You can put multi-unit abutments over these connections for changing the angulation if required. In most of the cases, we don't require, because the 45-degree angulation is already inbuilt. So you save on to the cost at that point. And this is the kit which is brought in. These are the drills sequence. I will discuss again. These are the lateral cutting drills which we're going to introduce soon with this system. And these are the sleeves. So once you see the case, you will understand. I will come back to this picture again, and you will understand like when to use which part of the kit. These are the lateral cutting drills, which cut that section laterally. These are the longer drills. And this is the triangular lancet drill. When you feel a resistance in going further, to avoid slippage, you can use this drill. And as I said, that if you measure, you see the long drill here, the cut portion is kept at almost 22 mm. And this is the threaded portion from Norris Medical. And this is the threaded portion from Implant Swiss. Smooth surface, and here it's straight internal hex, and here it's straight external hex with 45-degree angulation, which is inbuilt. And if you want to convert it into regular prosthetic connections, you can put multi-unit over it. But yes, for implant level impressions, you don't require those multi-unit abutments on top. And this is the lancet drill, where you find resistance in cutting the zygoma. You can use this. So this shows you that it's 14 to 16 mm which you have to cut. You have to go from the inferior point to the superior, keeping your finger on the zygoma, and cut through. And we will see in a video where you will come to know it in detail. So I'm thankful to a few of the innovators, Rami Siv from Norris Medical, and Gorkam Sirs from Implant Swiss, Dr. Altug, who is the innovator in Implant Swiss, for bringing up in different designs. And yes, this is the kit from Norris, where we have different cut threads and the smooth and the lateral cutting drill and the depth probe. The basic requirements are the same, and from Implant Swiss the same pattern, but we have a few advantages in that system which I will be discussing in subsequent slides. So you can go with the internal irrigation as well as the external irrigation with your assistance. So how to proceed? Now spend some time on this, and we need to focus that how to mark the areas where we want to go. So you can mark infraorbital foramen, which you see in the purple circle on patient's face, and draw a line and safeguard zygomaticofacial foramen. So 4 to 5 mm from the inferior border of the orbit to the infraorbital foramen, and draw a line, and you can safeguard that region, because you can safeguard zygomaticofacial vessel posteriorly and the infraorbital structures, and a few of the anastomoses. You can safeguard. Your area of target is inferior to that region. So from when you palpate infraorbital foramen, draw a straight line along the infraorbital foramen down, and then again a straight horizontal line along with the occlusion, and you can bisect that line as you see here in the blue color, and this is the area where you are going to go with the drilling. If you want to place two zygoma implants bilaterally, unilaterally, like quad zygoma, you can adjust the space accordingly. So your first point is when you raise the flap, you give an incision, raise the flap, and when you start seeing the curvature, you decide your point of insertion. First point, you create a dip here, and along with that dip, you insert that non-cutting end of the drill. You have seen that drill first? Yes, this drill. Now you insert this non-cutting end in the dip which you have made in that circle, and choose this drill. This drill will cut it laterally, not in a straight fashion. So you create a groove here like this. You'll make a dip, and then, yes, you see here, you introduce that non-cutting end in that dip hole which you have prepared, and move this drill in a lateral fashion, like you see here. The drill is moving laterally. The non-cutting end is engaged, and the drill is moving laterally to create that seat. So one, second, and third picture shows you how you move the drill. So here you see the
This is the way how we go with the
How you
first
go with
drill,
the
like a dip hole, and then
how you create the
create
seat.
a groove. Okay, with the lateral movement.
You have to
And then
coordinate. You have to coordinate
take the
it
second drill,
with the external face,
which is smooth, so that you don't tear the
so that you
sinus.
know that
And
where
now
you are
you will
going.
use the third
And
subsequent
then you
drill,
introduce
in which you will go
this
in the
drill
zygoma
to
bone,
go further to cut the zygoma.
keeping
Now you
the
see,
pressure
it will cut only the
on the bed,
zygoma because the cut end is in
which you prepared with the
at the
diamond.
apex.
Okay.
And after cutting,
And then measure it with
you
the depth probe. Yes,
introduce
you
the
can.
depth probe.
So that, oh, no, you don't have to go there. Okay, from here. Yes.
So now you introduce your depth probe and see the second marking at the crest. And second marking shows you
fifth
which
marking,
length of the implant
fifth marking
you
shows
require
you
from your inventory, and it is 40 mm.
1, 2, 3, 4, 5, 40 mm. 40 mm implant you require here. Okay. Thank you. Thank you.
She told me that if you don't introduce me in your presentation, you won't be allowed to present. So she's my daughter, and she took advantage of the lockdown period where they don't used to go to school. And now you have prepared the seat, and you are introducing your longer drills, and you are cutting. You're you're keeping once you are about to reach the second exit, you are going to keep your finger on the patient's face from outside so that you feel the exit. And the moment you feel the exit, you retrieve the drill and introduce the depth probe to know the length of the uh, implant. And this lancet drill helps you very much because in one of my case, I was slipped towards the lateral wall of the orbit, which I will share with you in the last slides. And this drill was not there at that time. So it really helped me. Now we don't slip, we go along with the resistance and then introduce the subsequent drills. So this shows you when you introduce the depth probe, there is a flat end. You take it back, it gets locked, and then you see the markings. You can see here the second last marking, and the reading is given on the probe what length of the implant you need. So it's simple. You place the implant, and likewise you go. The only thing is, I want you to practice it manually before you proceed with the guides. So this video will show you how to proceed. Create a dip hole, introduce the non-cutting end, and move it laterally. Now you have created the groove, and through that groove you are going and piercing the zygoma. So we call it with the different names: point A, B, C, X, Y, Z, whatever you want to keep, you can. Point A can be given to the first entry point, and exit you can give point B or C. So it like A, B, C, whatever you want to name them. But your focus should be your direction. So now we see here first dip with the with any round bar, introducing it, and as you move towards the sinus, you can choose the moderate burr. There are three burrs like this: coarse cutting, medium grit, and fine cutting. So as you approach near the Schneiderian's membrane, you can choose the third smooth burr, which safeguards that membrane, and you see this. Now You have to exert pressure while creating this seat, palatal pressure. And as I said, always correlate it with the, no, it'll be audible. Switch it off. Then if you create the, if you prepare the seat, you should always correlate it with the external face, whether you are going towards the eye or the targeted area which you have decided. As I said, you can give any name A, B, C, A to the first point, B the crestal portion, and then joining it with the point C at the exit of the zygoma. So A, B, C, and can be patient. Not don't be in a hurry to create the seat, because seat is very important. Implant will be placed only if seat is prepared well. And then with the palatal pressure, you keep moving forward. Your implant will start tightening itself when it is engaging those threads in the zygoma. Initially it will be loose, but once you start engaging the zygoma, you will start feeling the torque. And this is how the implant is seated, and rest of the regular implants were already placed, and prosthetic connections were joined, and the impression was recorded, as you see in routine what we do. And externally, if you want to see on the model, yes, this is how your implant will look like. So it's easy. It's not a tough job to place zygoma implant, but yes, learn and practice, as I said, and then go ahead, do a lot of practice on the models, on the stereolithic models, and proceed on to the cases under supervision. Zygoma implant is placed following an extramaxillary protocol. In most of the cases, bypass of the sinus membrane is being done to safeguard it. In extramaxillary technique, the implant is anchored in the zygomatic bone and not in the alveolar bone, resulting in a high torque placement. The prosthetic platform is shifted buccally to a better position for restoration, as I discussed in the initial slide. Special drills allow the clinician to carve a clean tunnel, those lateral cutting diamond burrs we are discussing. These special drills allow the clinicians to carve a clean tunnel preparation with minimum risk of damage to the membrane, and a wide range of multi-unit abutments, and in few designs the inbuilt angulation serve a great need for prosthetic success. We have included both Implant Swiss and Norris Medical and a few other companies in it, so they come with a different design. Finite element analysis. This test, what this test is. So it's a type of computer program that uses the finite element analysis method to analyze a material or object and find how applied stresses will affect the material or design. FEA can help determine any points of weakness in design before it is manufactured. So basically, it's a manufacturing uh, thing, which because until they pass this test, they don't get the certification to come into the market, because this test is very important. How it generates stresses on the bone and whether it will be able to withstand the masticatory forces, it won't fracture like that. So these pictures will show you how the stresses are being generated on different parts of the skull when you chew, and they said that the 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 forces which they calculated after placing zygoma implant, the bite force is more is has increased now in comparison to the natural dentition. So the bite force in case of zygoma supported rehabilitation is more than the natural dentition and than the conventional implants. So this also said that the bite force increased significantly with the support of zygoma implant. The use of zygoma implant in the restoration of maxillary defects improved functional outcome and patient satisfaction. This is how we proceed with some of the cases. This
Now
is a
it is.
case. Let me tell you, this is a case when I prepared a tunnel, and when I was preparing the final steps in the tunnel, I was going with the last drill. So the zygoma, the lateral wall of the maxillary sinus, it got fractured, and but zygoma bone was tough enough, so nothing happened. So if even if it fractures, but you have got the stability in the zygoma, you can go and proceed with the placement of the implant, because the fracture is undisplaced and it is only in the weaker portion of the maxillary wall.
And now you can see the kind of fracture the bone here, right?
This is the place where you want to go with the zygoma bone volume along with the maxillary wall, and a insertion point has been highlighted. How you go with the first point, then the lateral, and then proceeded with the placement of the implant. And this is pterygoid. How to do pterygoid implants. So these yellow dots, they show you that if I would have gone through these yellow dots, I would have gone in a I could have gone in a better position. But since we were little beyond that point, the implants were failed. So this is a case where we went with the pterygoid implants first. How you plan your position, your sequence. Once a case comes, I would say that proceed with the pterygoid implants first, with the regular implants, and then in the last you should proceed for zygoma implants. Because if you get tight anchorage, good stability from your pterygoids and from your regular implants, you go with the that support. But if you meet with the failures, then you can opt for zygoma, quad zygoma, and other uh, uh, options like combinations. So this is the pterygoid implant, how it looked like. And this is the technique which is being followed. So how we are going in this direction? We have to go in the pterygomaxillary pillar, right? One of the diagram will show you in the subsequent slide. We go along with the resistance, the medial pterygoid plate, the lateral pterygoid plate, and in between them you finalize your angulation and go from the maxillary tuberosity or slightly anterior to it, give a slight tilt, and this is a blind procedure which is under the control of your tactiles. So you keep a watch on your tactiles and proceed at very slowly until you feel a drop. Whenever you feel a drop, it can be due to the deviation in the angle, or it can be like you have paced the whole thing. So the maximum length which they say is 18 to 20 to 22 mm. So in a range of 18 to 22 mm, you can tap and proceed at along with the resistance. So don't stop until you feel the resistance, but keep a track on like you have gone till 18 to 20 or 22 mm. It's not like you have gone till 26 mm, still you are feeling the resistance. You can meet with the bleeding if you go more posteriorly because of the pterygoid plexus of veins present there. And yes, very important vessels too if you go more posteriorly. So this will show you like if you go more posteriorly, you can break this point. But since you are going to engage in the pterygoid plates, even if this fractures, doesn't matter. But to safeguard yourself, you can choose this point slightly anterior to it, and then start going backwards. You can even go through the posterior part of the maxillary uh, sinus cavity, and then piercing it through, and then in the pterygoids. So they say that average distance from edentulous maxillary tuberosity to pterygomaxillary fissure is 18.7 mm. Normally, we place 20 mm implant when we hit the pterygomaxillary pillar, which is here, and this is the fissure between the yellow and the orange line. And from another angle, if you see what kind of angulation you anticipate here, is this towards the medial pterygoid plate. I'm showing you this angulation, but you can be in between those plates. And these are the osteotomes, sharp and blunt, 2 mm and 3 mm. So after you creating a seat with the 2 mm, you can proceed with the 3 mm and then straight away insert the implant. If you find resistance in placing in going ahead with these osteotomes, you can use these drills, which are 2.3 mm and then 2.8 mm and so on. Yes, I was discussing that case which I've shown you, that if I would have gone, I could have gone through these yellow dots, I could have saved it. Yes, now we will see like what I was saying. So these are the implants which were failed. These are two pterygoid implants, and after 3 months they failed, and then we proceed from anterior in placing again the pterygoids. Until then, we gave them complete removable denture for their dentition to function, and this is how we corrected the angulation. So as I say that, go always along the resistance, and always choose a point anterior to your terminal point. So two zygoma, one on each side, and two pterygoids. This is how the zygoma seat is being prepared. You can appreciate Schneiderian's membrane. You can release this membrane. Once it is exposed, you can even release the membrane to safeguard it. And two zygoma and two pterygoids in place. And this dentition is being given, which is again changed. This is an interim dentition because we have to rehabilitate the lower dentition too. So we need to change the upper dentition. But for that phase, we had to give this dentition. Another case who came to us like this, and she was very upset. Believe me, she was like, "Doctor, nothing will happen to me, even if you try." Okay, but she was telling me that I won't say you anything even if you fail. So go ahead. And then we scanned that case, and as I say that we are instruments in the hands of God. He's always there, and when patient trusts, doctor trusts, sometimes those miracles are always there, which are going to help you. And this is how she looked like after she is being rehabilitated. And what I got from her were the blessings from her heart. A very warm hug from her at the completion of this phase, and you can appreciate the smile not only from the teeth but from her heart as well. This is how we proceeded with the case. As I said, prepare the groove, and you can see here once you are going from going in the left side of the patient, how much right tilt you have to give. You see the palatal pressure, because you are not going to invade in the orbit, you are going to invade in the zygoma. So always keep a check while proceeding. So these are the pterygoid implants. Two pterygoids, two zygoma implants, Swiss zygoma with the external hex, and one implant in the incisive foramen. Now you see the kind of soft tissue she has after repeated ill-fitting dentures. So we removed all that. We again gave her interim with the smile which you are seeing is interim. Final smile will be delivered, but she is happy with the from past 8 months with that interim prosthesis. And these are the steps which were these are the regular steps how we record in routine cases with the pattern resin for avoiding for minimizing those micro movements while impression. One screw test, and this this is the prosthesis all on five incisive canal and zygoma and pterygoids. What I was worrying was what you can anticipate here from patient's point of view is the phonetics because you have placed implant in the incisive canal, and when you are placing the implant in the incisive canal, always keep in mind that when patient speaks, he is going to touch the anterior part of the tongue at a point where your implant is being placed, and the prosthetics can again hinder the speech. So you have to really keep a check on that while placing an implant, because once you have to frame the final outcome in your mind before you proceed with the case. So go along with, and this is the post interim prosthesis to zygoma, incisive canal, and the pterygoids. And this is the post CBCT. We will move little fast here. This you can see how the pterygoids, hardly any bone, but we were able to place implants in those positions where there was stability after placement of the implant. So pre and post. And then you can do intraoral welding for your prosthetic placements. And this is being done with the help of Bredent composites. And you can anticipate two bilateral and four implants in the anterior zone 1, and then in support of, yes, you can place pterygoids again here, but if you would have placed pterygoids because lower was rehabilitated by a clinician earlier, so we have to proceed accordingly with the upper to match with the occlusion. So this was the protocol we followed, and this is the post to show you how the implants they lie in the zygoma. See, very less bone. You should be very patient enough to plan your case and always keep a check on the direction how you are proceeding and go ahead. Another case where doctor planned all on four, but fourth implant got popped out, and what to do now? Patient doesn't want to wait. The buccal wall has been lost here. These three are well integrated. One is slightly failing, but yes, you can say ailing, but not failed. So what to do now? So then you look up and you see for zygoma. So we went ahead and checked it and placed the zygoma implants under local anesthesia. And these are the prosthetics style, and you can see very well the 6 to 6 rehabilitation. Now you see, these are the only three implants which were present. Fourth implant is placed uh, as a zygoma implant, then pterygoid with the help of pterygoid. So now two pterygoids, two zygoma, they assisted the case, and it was rehabilitated accordingly. And this picture will show you how you apply pressure with the lateral drill.
Anything more towards final. Final.
So I think it's clear now how to prepare the seat. And once the seat is prepared, you pierce that zygoma through that seat with the longer drills, number 1, 2, and 3. And how it is being done will be shown here. Once the seat is prepared, you introduce the longer drills. And keep your finger on the patient's cheek from outside in that direction and feel that exit. And keep a check on the marking of the drill where it matches with the crest. So you can see the second last marking without piercing the Schneiderian's membrane on the model. And yes, in some cases you can graft the site where you meet across with some of the defects. Another case, patient was wearing removable denture. And as I said, mark on the patient's face. This is the infraorbital foramen, mark it. And for 3 to 4 mm, you beneath that you safeguard with the green line. And below that, you can see from where you have to start place with the direction of the zygoma, the prosthetics, and you can mark on patient's face. This is not marked on patient's face in this picture, but to show you, it is marked on the picture, not on patient's face. So we planned it like this: the conventional and the zygoma implants in combination in terms of in correlation with the CBCT, and this is how the implants were placed: two zygoma and some regular implants wherever we find the bone. This is our place of going when we select zygoma. Now, if you select zygoma from anterior, you have to move from anterior to zygoma. So you need longer drills. So there are long and short set of drills. Once you are approaching from anterior, you require longer drills. If you're approaching from premolar region to the zygoma, you require shorter drills. So this is how it is. That is why the two sets of drills are there in the kit. This is again to show you how you mark the lateral groove with the palatal pressure. You create a seat, and then through that seat you go with the longer drills. And then you start placing torque in your zygoma. So this is how you torque it in, and you can very well anticipate the site which you require here. The lateral groove and the zygoma. The angle is being corrected by putting internal multi-unit abutments. But in case of implant Swiss, you have inbuilt angulation. You can, without the use of multi-unit, you can place that implant. You can see how, after creating a lateral groove, how to proceed. And this is the outcome, prosthetic post outcome. And again, the same prosthetic protocols, and the patient is happy. So she was having RPD earlier, removable partial denture, which is replaced by the other thing. Now we will go to one of the interesting case before we finish with the presentation. This is how we conduct live courses in few of the dental colleges, where we perform surgeries under general anesthesia. So it's your choice, like whether you want to, according to patient's compliance, you want to go with the general anesthesia or with the local anesthesia. But if you choose local anesthesia, number of cases will be increased in your practice, because most of them, they don't go for general anesthesia just to rehabilitate their teeth, in India especially.
At 20-25 minutes.
So this was one of the live workshop where we rehabilitated this patient, and the question session was
Beyond 20, it slips
live
like this.
during the operation.
By default, it slips after 20-25 minutes. So if you want to tighten it more, you have to press apically, lock it tightly, and then again.
So yes, now we come on to surgical guides. How the now manual you have seen, to avoid slippage near the orbit, you can use these uh, guides, Dr. Zygo guides, where we need a CT scan of the patient, and a stereolithic model along with the guides will be delivered to you. So you can practice before the patient. You can practice on his or her stereolithic model, and then proceed with the case. You can see the orientation grooves. After creating the grooves, you can place these sleeves, and now they guide you that you have to go only through these holes. You cannot go here and there. And believe me, they are very economical, and you can proceed with the cases after your planning through this software. So as a beginner, you should proceed with one of your case with the freehand surgery under supervision. Second case, you can proceed with the your own hands, again under the supervision. And third case, you can proceed with these guides to safeguard you, and then you can move and do freely in your practice. These are the guides which are stabilized on patient's jaw like this, and then proceed with the case. This is the stereolithic model, and this is how the guide is being fixed. This was done in southern part of India, And you can see Dr. Anshul and one of my colleague, Dr. Neeraj Patel, on the indented on the drill, on the guide. Dr. Anshul is my partner for Dr. Zygo, which is patented under our name in India. And this is the lateral cutting bar, which is introduced, and you can cut the lateral seat, prepare the lateral seat, and after this you can go with the subsequent longer drills to cut the zygoma. And you remove that after preparing the seat and place the implants like this. Buccal pad of fat can be retrieved for better soft tissue healing. And this is how the quad zygoma look like. These implants are placed anterior-posteriorly, so the image is being superimposed. These are the post. Thanks to Dr. Eagle Balan, who's the co-designer in Norris Medical, my mentor, and I'm very thankful to Rami Siv. And now I'm very thankful to uh, Mr. Gorkem, who brought Implant Swiss, the wonderful design in Zygoma, three designs in fact. One for oncology, another one for maxillectomy cases, and the third design is for where we have crests, threads on the crest of the implant. So three Zygoma designs and beautiful prosthetic lineup. If you go to implantswiss.com, and initially we said that no one should die with their teeth in a glass of water, and thankful this statement is evergreen. It will stay forever. The only thing is law of karma. It comes, whatever you do, it will come back to you. So he has done a lot of things in his research. So he's relishing after, even after he's gone from this world, but not his works. They will still be live. So thanks to Dr. Professor Brenemark for giving us this opportunity that we are talking with our colleagues like this. And this is the case which I was discussing when I slipped in the lateral wall of the orbit in my initial cases. So a line is marked in the infraorbital foramen, a straight line and occlusal and bisected. And now this is your target zone. As I say, always you can draw on patient's face externally. And this is the implant which is placed. So sometimes even anatomy is most of the times it is variable, and it will test you. And I feel that you know whatever happens to you, it will teach you so many things. So what happened here, we maybe pierced some of the vessels, periorbital vessels, and patients started developing intraocular hematoma, and there was a lot of pressure, and even the diplopia started developing. We retrieved the hematoma, drained the hematoma through the site which is prepared with the suction, and press the eyeball inside, and wait for some time. And now the site is already prepared. What to do? If you leave the site, what will happen? There can be a communication uh, which can lead to complication. I thought of okay, everything is normal now. In 30 minutes, I will place implant in that prepared site. So the torque was good enough, and this case was done almost 5 years ago, which was doing well. And this was almost 20 days post-op. Now you can see the right eye; it's completely healed up, and the implant is very well stabilized in the bone. But this is what we didn't have our lancet drill, which is introduced by Implant Swiss now to safeguard this slippage. And yes, you will learn how to manage chair side complication. Mm, thanks to Almighty again. And message to remember: beware of slipping from the target and avoid hitting the orbital rim. Be slow and keep a check on the direction. I kept on repeating throughout my presentation. Yes, you have to keep a check, and that's the key to of success. My place of practice in northern city of Punjab, Pathankot, a very small town with almost 1.2 lakhs, 2 lakhs of population in comparison to other states in India. And this is our place of practice. Another place of practice in the vicinity of Himalayas. Uh, Please note down my email and give me an opportunity to host you whenever throughout the world you are here to visit this part of India. And this is how we conduct courses. Last course was with the Japanese. Uh, they came in a group of 8, and in my clinic, they had that opportunity to perform in the assistance and on the patient. And it was a very confident, very good interaction with them. So you all are invited to perform on models on in assistance under supervision on patients, and I thank you everyone here, and I invite the set of questions, your queries, what all, if I can. Thank you for being a patient listener. You said, what is your anesthesia protocol? It's a local. I mean, if you are talking in terms of local anesthesia, we give blocks, infraorbital block, and posterior superior alveolar nerve block, greater palatine nerve block, and uh, yeah, and infiltrations. And if you're talking about general anesthesia, yes, my anesthetist decides on the systemic condition of the patients, like what kind of doses he has to introduce to go to get him into the procedure. Dr. Rohan Virani from Mumbai, he's asking, like, do you have any cases done with one piece basal zygoma? No, I have no experience in basal zygoma, so I don't have that inventory lying in with me. Uh, for local anesthesia, do you inject any anesthesia on the region of zygoma extra orally? Yes, you can. You can. There is no harm in it, but I do it intraorally. You can go intraorally, and even you can, after raising the flap in a slow manner, you can proceed injecting with the anesthesia intraorally, because then you get the access to inject intraorally too.